All right, I'm going to tell you about the V60 ventilator. The ventilator can be used for non-invasive ventilation or invasive ventilation. Non-invasive ventilation is ventilating a patient by just placing a mask on their face rather than having to put a tube into their lungs, which would be invasive ventilation. So this is a newer ventilator compared to the older Bipap Vision. The best thing about the upgrade is that there's an internal battery inside. So with the internal battery, you can have the patient on their settings and be able to transport them somewhere else in the hospital without having to take them off, wait for them to be transported, and then put them back on. So that's the best part about the upgrade. And then it can plug in. Instead of running on battery, you can still plug it into an electrical source. That'll charge the battery also while it's plugged in. And then putting a circuit on, we always want to start with a filter and filter the inspired air that's going to the patient. And what's unique about the circuit is it has two lines. So the small bore tubing is going to sense pressure that's in the line. The large bore tubing is actually going to deliver the flow of gas going to the patient. On here there's a hole, and the purpose of the hole is for exhalation. So excess flow will come out the hole, as well as exhaled air from the patient will go out the hole. So that hole should never be covered, it should always be left open. So we've got the circuit connected, and then the next thing we do is we select the size of mask that we're going to use for the patient. And let me show you some of the masks that can be used. The masks have a fancy headgear, and the purpose of most of this is to hold it in place on the patient's face. But the biggest problem with having these masks on the patient's face is it puts pressure over the nose. And even after a couple hours of pressure over the nose, you actually see skin break down and the skin wears away, and they develop sores very quickly, pressure sores. So the design of the mask is to pull the pressure away from the bridge of the nose. So that's the purpose of this. And then the headgear is just to hold it all, give it some flexibility. So this mask is a size small. And that's all we have here is smalls. This is an interesting mask. It's called a total face mask. So it covers the eyes, the nose, the mouth. And it looks scary to have this on the patient, but they say it's the most comfortable. So you would think, oh, even though the eyes are receiving pressure during inspiration, it would damage the eyes. And it doesn't. They prefer this. It's more comfortable. And a nasal mask can just go over the nose and deliver the positive pressure. This is for patients that can keep their mouth closed, because once their mouth opens up, there's so much of a leak of air flowing out that you can't really keep your pressures. So nasal masks are best if you have a patient that can keep their mouth closed when they're on this ventilator. And then we can also hook up to an endotracheal tube or a tracheostomy tube. And we're going to simulate that in the lab with a Tesla. As far as telling you the size of mask, every mask comes with like a little gauge, small, medium, large, so you can hold that up to the patient and then decide on the right size. So I'll connect this to a test lung while I'm going through everything. All right, so I'll go through the screen. At the very top of the screen is the alarm silence, and when you hit the alarm silence, you get 2 minutes of silence of any alarms that are occurring. And then you can cancel the silence by hitting alarm reset. But if there's any alarms that are still active, they're going to start alarming, and then you're going to hear them. Informational message will just list all the alarms that are currently going on. They'll be flashing in red. So below that there's a box, and it has a bunch of numbers in it, and the purpose of all those numbers is to monitor different things with the patient. So the first thing that's listed, it says exhale, and it shows blue, and then it says timed. So if the patient's breathing spontaneously, can you see where you get an SPONT? So that's the patient breathing spontaneously. But if they stop breathing, it's going to say it's a timed breath, meaning that a certain amount of time went by, they didn't take a breath, so the ventilator delivers a breath. So that's what the timed is for. The next thing it keeps track of is the patient's respiratory rate, the tidal volume. So depending on how much air flows into the lungs and flows back out, the ventilator can calculate how much air is just excess flow, either around the mask or, yeah, probably around the mask. It can calculate what the patient's tidal volume is. Minute ventilation will be the respiratory rate times the tidal volume. It'll give you a minute volume. And you want to see minute volumes in your adult patients about 5 liters per minute or more. If it's lower than that, now we're concerned that they're not blowing off enough CO2. Peak inspiratory pressure is a concern for us because we know that too much pressure damages the lungs. So that's something that we monitor, and typically with non-invasive ventilation, we're setting the pressure. We're saying, this is the maximum pressure during inspiration, so it's not going to go into the higher numbers since we're setting that inspiratory pressure. The patient leak right now, it's showing dotted lines because instead of having a mask, I just have a test lung on. But when you're putting a mask on a patient's face, you want there to be some leak around the mask. So if you think you're going to put the mask on and make it really tight for no leak, that's going to cause a lot of skin breakdown, and then the ventilator doesn't work as well. It wants a leak. It wants a leak between 10 and 60 liters a minute. Even though all that air is leaking around the mask, it can still calculate tidal volumes and come and sense patient effort, which is important. Patient trigger, it says 31%. That means 31% of all the breaths that were given, the patient initiated them. The rest of that, there was apnea and the ventilator just gave timed breaths. The TI/T-TOTE stands for inspiratory time compared to total time. So inspiratory time usually should be like 33% of the total time because you want the rest of the time to be for exhalation. Usually takes twice as long to exhale the air that we breathe in. So we like to see 33% or less. And then next we move into the graphics, and the graphics are just showing us the pressure that's building during inspiration, the flow as it's going into the patient, and then the volume that's delivered. So we have the digital readout, and then we have the graphics. And then it has something fancy where there's a cursor going across the screen, and we can stop the cursor at a certain point in time. Let me stop it at peak inspiration. So I guess I stopped it after peak inspiration, but it shows what the pressure was, where the cursor was stopped, what the flow was, and what the tidal volume was. I say below that it says active mode, S/T. So that's the most common mode that you're using with non-invasive ventilation, and it stands for spontaneous breaths /T. And T would be timed breaths because the patient is apnea. So it's a backup. Below that are the typical settings. So the first thing it mentions is IPAP, and that stands for inspiratory positive airway pressure. So during inspiration, there's going to be a positive pressure that pushes the air into the patient's lungs, and we set how much pressure we want that to be. The higher that pressure, the bigger the tidal volume. And below that is EPAP for expiratory positive airway pressure, and that's the amount of pressure that's kept in the lungs at the end of exhalation. By keeping a positive pressure in the lungs at the end of exhalation, we can help improve oxygenation. We can stent the airways open to allow better gas exchange. So that's why we use the EPAP. So IPAP will ventilate, EPAP will oxygenate. Next to that it has a rate, but again the rate is only for apnea. The way that these ventilators are set up, with a rate of 12 as your apnea rate, that means an apnea breath will be given every 5 seconds if the patient's not breathing. I don't know if you know where I got the 5 seconds from. But 60 seconds divided by 12, that means 5 seconds for each breath. So it'll give a breath, or the patient will take a breath, it'll wait 5 seconds, and if the patient's not taking another breath, then it'll give a timed breath. So that's the apnea rate. When it gives a timed breath, it needs to know how long to deliver the pressure, so you have to set the inspiratory time. The next thing is rise, is what it says, and it shows the number 5. When pressure is delivered to the airway, initially we can start off very slow and deliver it like a gentle rise to pressure. Or if somebody is air hungry and they're breathing really fast, we want to give them a fast rise to pressure. We want the air to go in really quickly and reach pressure. So we would set a fast rise to pressure for somebody who's short of breath, or if they're just breathing normally, then a slower rise to pressure. And then where it says off, this can be used on patients that have sleep apnea, and sometimes they have a hard time falling asleep when this pressure is blowing at their face. And it's better for them to fall asleep first, and then the inspiratory pressure comes on. So we can set that ramp, meaning that the ventilator will wait 5 minutes, 10 minutes, 20 minutes, whatever we set. I think we can wait up to 45 minutes before it'll actually come on and start blowing the air while they're sleeping. Oxygen percentage, it says 21%. And right now we're not connected up to 50 psi oxygen. But if we want to deliver more than 21%, then we're going to need 50 psi coming into the back of the ventilator. Across the bottom, there's alarm settings. I'll go through that in a minute. I'll show you the modes in the menu first. The modes of ventilation that are available on here, the first one is called CPAP, C-P-A-P, for continuous positive airway pressure. And that's just a continuous pressure. It's used for somebody who they're not oxygenating well. We have them on a non-rebreather and still their O2 saturation isn't high enough. The positive pressure will improve oxygenation. So we can put them in CPAP mode, put the mask on, and just deliver a constant positive pressure to help their oxygenation. And then the other use for CPAP is patients that have sleep apnea. When the airway obstructs when they're sleeping, there's a way to stent the soft tissue open, and that's using CPAP. The next one, it says batch S/T. Batch just means when we go in there, we can set the whole batch of settings at one time. I don't know why they put that word there. The S/T mode is we're giving spontaneous breaths, and if there's apnea, you're giving timed breaths. And then pressure control ventilation, we can actually ventilate a patient that's trached or has an endotube in, and we want to give them a mode called pressure control. So pretty much, go back. So I showed you modes, and now in menu, one of the things you do is go to mask port, and for different masks, there's a setting on the mask that shows you what you're supposed to select when you're using that mask on this ventilator, and it has to do with the amount of leak that occurs with each mask. So that's basically what you're setting, is the type of leak. You see how this has a different number? So if we were using this mask, we would select a different number.
Yeah.
Do you want to try it on and show them? It's not clean. I don't want to put it on your face. You're going to alcohol it and we can put you on it?
Yeah.
All right. All right, so we'll put this on Susie's face, and that means that we have to select the correct leak value, which is, looks like number 2.
1 to 2.
And then accept. And you're going to alcohol it before you put it on?
Yes, I am.
All right, to put this on Susie's face, I'm not sure she's going to enjoy an inspiratory pressure of 15 centimeters of water. So I'm going to turn that down. So when I touched on it, it gave me some arrows to make the changes. And I'm going to give her an inspiratory pressure of 10 centimeters of water. And an expiratory pressure, I'll put at 4 centimeters of water. And then I just hit accept.
You're gonna sit down or you're gonna sit?
And then activate batch changes.
Okay, I activated the batch change. All right, so I want to make sure there's a flow going into the mask before I put this on her face. How to clumsily attach this while it's on your face. I can get to go on.
Just snap.
Mm-hmm.
Yeah. Very good.
And then
Is that
adjust the
tight enough?
straps.
So the leak should be between 10 and 60, so it's
Mhm.
too high.
So,
All right, so if it's too high, then, well, it came down.
I did.
Okay.
I
Yeah.
just adjusted it.
You did?
Susie, sit to his side.
Okay. All right, perfect. So now we can monitor Susie breathing on spontaneous timed or BiPAP. So we're delivering an inspiratory pressure of 10 centimeters of water and an expiratory pressure of 4 centimeters of water. We want to make sure that our leak is less than 60 liters a minute. Is it?
Yep.
Yeah, so we have 56 liters a minute, so we're just under 60 liters a minute. Are we delivering an adequate tidal volume?
6
So Susie, we want you to breathe normal, just in and out, nice and easy breaths. So you see the tidal volume fluctuating, but it's about 400 mLs. So that's a really good tidal volume for her, and we'll keep that inspiratory pressure at 10 centimeters of water.
So we increase the inspiratory positive, that will increase your tidal volume.
Mm-hmm. Yeah, very good. Yeah, so increasing this will give us a larger tidal volume.
And
All right, so while
she
Susie's-
holds her breath, it gives the spontaneous.
Hold your breath, Susie.
Oh, you want to see the timed breath?
Yeah,
Oh, okay. Did you see it?
Yep.
hold on, give it a second. Yeah,
Yes, that said
there you
timed
go.
at the top.
The orange line shows us that it was a time,
it's
and now
on.
she's
So
spontaneous.
Can she start breathing now? Very good. All right, so we see all these alarms that were occurring, and we just hit alarm reset to make them go away.
Are we doing the lead?
Should we set alarms while she's keeping it on?
Occasion disconnect.
It's just sensing a big leak and it's saying patient disconnect, even though you're not disconnected. Oh, it slipped under your chin. That's why.
The size of the mask was probably too big for her.
Maybe.
Yeah. Yeah, it's a one size fits all, so. it's
You gotta
very
tighten
possible.
up the other side. That's probably hard. I only tighten one side up.
Oh,
You have to do the other side.
Do you want him to tighten it so we can set alarms, or you're okay like that?
Go ahead, she
I think
said.
she said keep going.
Yeah, are we done?
Yeah,
Oh.
unless you want to set alarms.
All right, let's set an alarm.
Set some alarms for Susie.
All right, so high respiratory rate, typically you set it at 30 per minute, because if somebody's breathing faster than 30 times a minute, you want an alarm so you can go check on them. Her high tidal volume, we can be
That looks
generous
good.
with that, that's not an issue really. The high pressure limit, if for some reason more pressure builds up in the circuit than we expect it to, we want to get an alarm, so usually 10 above the normal
Is that
pressure
the same
setting.
as your PIP? No?
Mhm.
Yeah, you're right.
Yeah, so your peak inspiratory pressure is 10 centimeters of water, and you would set this 10 centimeters higher than the actual. The low minute volume is a concern if they, I don't know, if they have an obstruction in their airway, they stop breathing, and the minute volume drops to like less than 3 liters a minute, there's a danger there, and we would want to hear an alarm. If their respiratory rate is low, we would want to hear alarm. Typically, you set that to alarm if the respiratory rate drops to less than 10 per minute. Low tidal volume, you see what their normal is, and then just set it lower than their normal to get an alarm. And low pressure, you set that usually 5 to 10 below the normal inspiratory pressure. So if there's a disconnect, you're going to get an alarm. And you can have a delay set of, right now it's saying 30 seconds. So sometimes the patients will lift up the mask, they'll want to take a sip of water, or they lift up the mask, they want to say something and then put the mask on. You don't want to have a constant alarm, so that's why there's a delay for that low pressure alarm. And that's it.